Hello, everyone, and welcome to Ortho NorCal webinar series. My name is Leah Arutinov. I'm the marketing coordinator at Ortho NorCal, and I am honored to host this event together with Dr. Nicholas Abidi and Dr. Michael Nuzzo. Both are orthopedic surgeons within our practice. The presentation that each surgeon has prepared for today is geared primarily towards patients and intended for patient education. You can direct your questions to the panelists by typing them into the chat screen during our question and answer session. And if you have any additional questions, you can email us at marketing@orthonorcal.com or call 408-412-8100. With all that being said, I would like to introduce our first panelist, Dr. Nicholas Abidi. Welcome, Dr. Abidi.
Thanks, Leah. So I just want to clarify, though, that we're going to stop and answer questions at the end, correct? Not as we're going along.
Yes, at the end. I'll address those during the Q&A session.
Good, yeah, because I can't see the chat screen right now because I got this thing on full screen. So I'm going to go through the talk, and it'll take about 25 minutes or so, and then we'll leave 5 minutes for a question and answer, and you can email some later on. So thanks for joining us. Today we're going to talk about the modern management of hip and knee arthritis. We'll cover some conservative care, including medications, exercise, weight loss, and then talk about the surgical indications and some of the surgical techniques. And essentially it's down to, if you want to stay independent, you're noticing a loss of function, you can't sleep, you need to see a doctor no matter what it is, whether or not it involves us or your primary care physician. Primary care physician is always a good place to start out, in my opinion, and they should be the keepers, and you should have a good relationship with that person. We also look for, just to remember this word, comorbidities, meaning other illnesses. And we're constantly trying to look at helping patients to solve those problems with or without surgery. And sometimes solving those problems means no surgery and less wear and tear on your body. So that mainly means losing weight and making sure your cardiac and blood sugar is in good condition. And that can lead to less problems overall. Those are the core messages at all when you talk to a doctor to make sure you understand that. So we'll talk about hip replacement, what the differences are, different surgical approaches. We'll talk about knee replacement, the differences between robotic and partial knee replacement, and we'll cover that a little bit with data. So ideally, the ideal body mass index in the US is below 30 to 35. Body mass index has been going up over the past couple of years for many, many reasons, including food, diet. In fact, we don't live in the community in the rural areas anymore, probably drive too much and sit too much at work. Every time your body loses a pound, your legs think you lose 3 pounds because you put 3 times your body weight across your knees when you walk and your hips and ankles. So losing a pound is a big deal. Losing 10 pounds, your joints feel like you lost 30. So don't think that any little bit isn't a minor deal. It's a big deal to keep losing weight. So that's the main thing. Focus on that, is keeping an ideal body mass index around 30 or so. 28 to 30 is the tops. People are mostly below that. When you hit into 28, it's considered a little bit overweight, but ideally nowadays it's not that terrible. The keys are non-impact exercise. So closed chain non-impact exercise, patients say they can't do it. They can't do this prior to surgery. The ones who say that basically gain weight after surgery. They never really follow through. Post-op, from our data, not just my opinion, but our national data sets. So most of the opinions I'm expressing are based on evidence-based medicine and journals and articles that we read and generate and write and have peer-reviewed discussions on. So the recumbent bike is also really good. It helps you stretch and exercise at the same time. And it's considered closed chain, meaning that it's less impact and doesn't generally stress your joints out. Now, I know the gyms are closed, so it's hard to do that. If you can't do that, there's something else we call Nordic walking, where you can use walking sticks to get around. That helps distribute the force between your arms and your legs. So that's really important to remember, to get out and get active in California, in particular in our area. Thank God we can do that. Non-operative management also can include Tylenol, which is not an anti-inflammatory medicine. Anti-inflammatory medicines are ibuprofen, Aleve, and other prescription-based drugs, which cut back on enzymes which eat the joints. People also have significant inflammatory disease. There are specific medications designed for that. If they have rheumatoid arthritis or psoriatic arthritis, they're more prescription-based and targeted therapies. But Tylenol is a safe thing to do if your liver's okay. Injections also include ultrasound or non-ultrasound-based steroid injections or lubricants, or platelet-rich plasma or stem cells. More recently, using platelet-rich plasma, which can have peripheral stem cells, is almost the equivalent of steroids, but it's very expensive and it's not paid for by insurance. But in younger people in their 40s and 50s, who are looking at joint replacement. Using platelet-rich plasma, taking your blood, spinning it down, and concentrating it can result in perhaps generating a little bit more vigorous fibrocartilage or hyaline cartilage, which is what you're born with. The hyaline cartilage that you're born with has less friction, it's more durable, it's the normal anatomy. When you have a scar in your knee, in the cartilage, you form fibrocartilage, which can fall apart in 3 to 5 years. So using augmentation like stem cells, which are at the base of this bone on the left part of the slide, or platelet-rich plasma containing stem cells might help you to make more durable material. But we know in clinical studies, it tends to make the knee last longer, in particular, if you're able to maintain an ideal body weight. So other athletes will use things like stem cells, and it's not magic, and it's not something that is a cure-all. It can be indicated in certain cases, but it's not really well determined that there are particular type of stem cells, like amniotic stem cells or bone marrow stem cells, that may make a mega difference right now. We just don't have data to support that. But we do know that platelet-rich plasma with peripheral stem cells can prolong the life of a joint in younger patients and avoid joint replacement potentially now based on evidence-based medicine. Hip arthroscopy, Dr. Nuzzo is going to talk about, and that can reduce the amount of what's called impingement if you have spurs and you're a younger person, or repair the labrum, which can postpone or eliminate the need for hip replacement potentially. It's mostly done in younger patients to clean up the spurs and repair the labrum and avoid arthritis progression with time. Patients with knee arthroscopy have meniscus tearing or cartilage tearing or loose bodies in the joint. When someone has an x-ray like this that looks normal with a normal joint space, not like this one on the right, they generally do better with knee arthroscopy with mechanical symptoms. The knee on the right needs to be replaced. There's no arthroscopy to solve that one. So when we look at patients prior to surgery, we're asking a bunch of different questions based on some research data that I published a couple of years ago for the state of California, and looking at what makes patients better with surgery and safer to go through surgery. And patients whose body mass index are up around 35 to 40, we send for weight loss coaching. And patients with vitamin D levels, we want them to be around 50, and diabetes, blood sugar, A1C around 7. We look at other factors like albumin and MRSA and look at functional pain scores, which when you're asked about this stuff in the office, we're asking you so we can look at you objectively and compare your data to thousands of other patients to see where you should be. And if your scores on these questionnaires drop to a certain level, we try to get it better without surgery or with surgery and kind of shoot for a target range. We ask patients to stop smoking at least 2 weeks ahead of time. And then narcotic use. When patients who are on chronic narcotics like Norco or oxycodone, we want to wean them down to Neurontin and Tramadol and Tylenol. And then use a regional anesthetic and a spinal to eliminate the amount of narcotics and heavy anesthesia potentially. When patients are on a lot of pain meds ahead of time, they need a deeper anesthetic, which prolongs the recovery and increases complication rates. We use this thing called multimodal pain control, which involves everything but a narcotic if possible, and then allows the narcotics to work better after surgery and involves less narcotic use. So less constipation, less nausea, less slow recovery, basically a much faster recovery. The trends in knee replacement is that knee replacements and hip replacements are going to go up substantially in the US, are already going up. 200% increase in hip replacements and 600% in knee replacements. People are getting younger. We think it's due to pediatric athletics. There was a pediatric athletic boom about 30, 40 years ago, and the patients are getting heavier as well. What are the symptoms of arthritis? Startup stiffness, night pain, and rest pain. We don't want people to be falling down before they come in to have replacements. We want them to be safe and stable, but when joints give out, people fall down and break their hips and their wrists, so we want to avoid that no matter what. So when you look at joint spaces, we talked about when do you have surgery? Well, this is a pretty good looking joint space. This is getting kind of delayed and things are getting worse. And we look at the pain and function scores we talked around 50 or so between hip and knee scores. And that's kind of what we're looking at for target range to talk about surgery or other interventions. And, patients are saying, you wait until you can't take it anymore. You don't want to wait until it's that long. That's the old way of doing things. It's better to kind of go with stuff at a supply-demand curve where your legs are strong, you're in good shape physically, mentally, and you're not in a dire straits. So we inject patients, send them to therapy, go through weight loss and counseling before replacement. Patients can go home almost the same day or stay overnight or be done in a surgery center because they're so tuned up that they don't require a long recovery process because they're in good shape ahead of time. So, bigger deformity, like in this patient on the left knee, requires a bigger prosthesis than the one on the right. And so we don't want patients to get bigger operations. We want them to get smaller operations and for parts to last longer. So if you look at the hip arthritis, it's due to wear and tear. It can be due to blood supply issues. It can be due to congenital deformities called hip dysplasia, shallow sockets, or breech birth. Those are common causes. This one's just a hip arthritis due to trauma that led to the bone narrowing down. The hip on the left is normal. The hip on the right has spurs and cysts. It's kind of narrowing down. The joint space is going away. So that hip needs to be replaced. This is a trauma. So this is a trauma where someone broke their hip and their joint's gone for that reason. And yesterday I did all of these things. So we did it for hip arthritis, for trauma, for hip dysplasia. Patient had these parts in yesterday. I took out and did a replacement on his younger patient. So we template the hip ahead of time. We kind of get the approximate sizes, helps us target what we're doing during surgery and improves the leg length issues. And also the parts kind of gives us an estimate on what sizes we're going to use during surgery. All the hip stems are similar now. I look at the different shape of the femur and determine which type of stem I use based on the thinness of the bone and the shape of the stem. The liners are generally coated in a way that they'll last longer. The younger patients, I'll use a ceramic head. Older patients, a chrome cobalt head. All the stems are titanium. They used to be different materials, but now they're all the same. And the goal is to really reduce the amount of pain and improve function so patients are able to ambulate better. An old incision used to be done through the back, and it was about 12 inches. That's about a foot-long incision. And yesterday, one of the patients I had that incision because they had previous surgery, and I was able to go through the front through a less invasive procedure. This is the traditional approach, making a big open in the hip and going by the sciatic nerve and detaching the tendons, and we don't do that anymore here. We reshape the cup like normal and put a metal liner in there and a plastic socket there. And then we put down the femur, the femoral shaft, like we talked about, that femoral component goes down. In the traditional posterior approach, we have to worry about hip dislocation precautions. Patients can't bend beyond 90 degrees because they risk dislocation. So, and they can't bend beyond 90 degrees either because they risk dislocation. They can't get in a car, they have to have special chairs. So I don't do posterior approach for that reason. It's a higher rate of dislocation. I do an anterior tissue sparing approach, which is less invasive. It's been around since 1947 from France, just a little bit different than the British approach. We don't have dislocation issues, generally less than 0.1%. And we use an x-ray for guidance during surgery to position the parts a little bit better. So it's a little bit more accurate as far as we're concerned. This is a right leg. We just go through the muscles and split the interval. And on an OR table like this, we use at Dominican Hospital and El Camino an x-ray guidance to help us to make the incision less invasive. And then we use these devices to help to hold the patient's leg during surgery to assist with the surgery. There's no routine dislocation precautions. We use x-ray guidance. Just about all patients can do it, but again, I want their body mass index to be between 30 and 35, and we get them to lose weight if they're not at that level, just to decrease complication rates in general. We can do both hips at once that way. And this is what it looks like in a patient that I did. This right hip was done 30 years earlier, 25 years earlier. The cup was too vertical, it's wearing out, and the hip was cemented. And we did them, past couple of years, and cup is more horizontal, hip is uncemented. It's a much smaller prosthesis, and it'll last a lot longer. So the patients in the older way of doing it were in the hospital for 4 or 5 days. Now we can do outpatient surgery. They go home the same day or they stay overnight. And patients are taking less pain medications. 20% are asking for pain meds at 2 weeks afterwards. So patients afterwards are able to golf and swim and bike within about 2-3 months. We ask patients nationally and surgeons nationally what they do. They won't let people run, jump, or jog or do contact sports or heavy labor with a hip replacement in general, no matter what the approach, because they want things to wear out that much. So what are the complication rates with total joints? The complications in anyone can be a wound healing problem, a blood clot. We give patients blood thinners like aspirin to prevent that, and pumps. We have you get the pumps ahead of time, and we stratify patients for risk and determine who needs to be on a heavy blood thinner and who can be on aspirin ahead of time. And the dislocation rates, again, are very, very low with the anterior approach. So that's the conversation about hip replacement. Again, we'll stop at the end for the questions, so we'll go into knee discussion right now as well. So the knee has 3 compartments, and we see arthritis based on trauma or inflammatory disease. It could be osteoarthritis or inflammatory disease. You can also have a trauma where the x-ray looks normal, but you develop a blood supply problem to the bone called avascular necrosis. That in particular can be addressed by non-weight bearing or nowadays injecting things like calcium phosphate cement to stop that from deteriorating further and maybe try to hold off on joint replacement. But when I trained in Pennsylvania, they really did joint replacements for all these things, and we don't need to do that all the time anymore. we can avoid that sometimes. So conservative care is usually cortisone, like we talked about, lubricants or PRP. Physical therapy always helps, and then consider stem cell or PRP or a combination thereof just to prevent progression of disease. This is a good looking joint space, again, an x-ray for a knee. And this is a knee that's bowed and the joint's bare bone on bone and has remodeling where it's crushed down like that. It's very unstable also. So this week we'll do physical therapy and basically set the patient up for a joint replacement. And when they have a deformity like this, they usually last a while, but every patient's threshold's different. When the outside narrows down, the lateral joint, it's hard. It's really hard because the knee is very unstable at that point, and they generally need to be replaced a little quicker when they have what's called a valgus knee. This is called a varus knee. So when they're knock-kneed, it doesn't last as long. It's harder to manage that way. What do we do as before joint replacement? Well, we do something potentially called subchondroplasty, which maybe avoids joint replacement. We can actually target a lesion that we talked about on the MRI and actually inject material, which is liquid bone, into the joint or the bone itself. So we have a lesion like this on an MRI, and we can actually target that with this material, which hardens up in about 5 minutes and supports that and prevents it from crushing down potentially. That's a calcium phosphate injection. So there are other cartilage surface transplants, which Dr. Nuzzo is going to talk about a little bit, so I won't get into that too much, but that's in younger patients. The joint replacement consists of 2 to 3 components: the femur, the tibia with some plastic in between, and then sometimes we resurface the kneecap. I don't have to do that much anymore. These parts are designed to last for 15 to 20 years with normal usage. I tend to spare all the ligaments except the ACL, which is usually damaged or not usable. And I also balance the ligaments. So why do knees not do well? So you might hear from your friends and neighbors, hey, my knee did great or my knee did terrible. 75% of patients are happy with their knee, 25% are not, because their ligaments weren't balanced properly in the way they're unstable. That can lead to premature breakage or loosening. In a study done by my colleagues where I trained with my partners in Philadelphia, the Sharkey and Hozak, they looked at a lot of knee replacements. And that's what they came to the conclusion, is there wasn't good ligament balancing. So I line up the hip, the knee, and the ankle to make sure everything's balanced well, and I've always done that. And we've used mechanical device before to match the flexion extension device called a tensor, or a soft tissue tensiometer, and that's the way total knees are developed, is this device in the middle. So we did this mechanically for 25, 30 years, and now we do it digitally. So we have robotic assisted knee replacement that doesn't violate the principles of what we're doing. And it has a robot that kind of helps me to do things. So the robot consists of a navigation system, like a GPS tracking unit. So we put reflective markers in the bone and then use this device as a digital tensor to use a screen and dial in the amount of tightness that we want in the knee and the range of motion. So we're able to kind of match that and get surface mapping by touching a probe and developing a 3D model during surgery, and then attaching the robots and actually doing the cuts by hand with the robot assistance, not the robot doing the cuts in this case, me doing the cuts, and then map out where we want the knee to be in terms of range of motion and tensioning for the patient. So young patient different than older patient, we kind of look at compromise and their alignment and really match the patient to their anatomy of the kind of cuts we're going to do. We don't put in generic knee replacements. So every knee is custom knee replacement basically. And so the robot really helps to actuate that better, like backing into your parking spot or a GPS unit, combines the best of all those worlds, plus tensioning the ligaments. So we tension the ligaments through a full range of motion and make sure it matches what your needs are based on your body and what it's telling us during surgery. So that results in some good data. So if we look at the literature and we look at registry data for the US and Australia, patients are satisfied 3-6 months in about 77 to 81%. With the robotic balancing Omnibot knee that I'm using right now, it's about 96% of the year. So that's substantially higher. And so that's published data from a registry system comparing robotic balancing with this balance bot to non-robotic balancing with a similar prosthesis. So that's the robotic assist knee replacement that I do, which involves ligament tensioning. There's also a partial knee replacement called a mobile bearing Oxford knee replacement that we do as an outpatient. And that's a truly minimally invasive surgery, which involves a mobile bearing. About 10 to 15% of patients will qualify for this. If you have arthritis in other parts of your knee, inflammatory disease, or pseudo gout, we don't tend to do this one because I don't want you to wear out the rest of the knee. I'd rather just get the knee replacement, depending on your age and your demand level. This partial knee replacement really saves patients time and money in the entire healthcare system. And when you look at the biomechanics of this knee replacement, the partial, it's very similar to a natural knee. Now, having said that, that robotic knee is pretty much catching up with that biomechanics of the natural knee as well. It's very difficult to distinguish that now in that knee. It's not as clunky as they used to be. So the robotic Omnibot ligament tension knee replacement feels pretty good. And it's hard to distinguish between that and a natural knee replacement, a natural knee now. Our centers have a Blue Cross Blue Shield centers of excellence that we've taken great pains to establish. I have to submit forms every 3 years for qualification and making sure we meet those criteria. We were ranked tier 1 also now by Cigna for our quality measures and our outcomes database management. We look at functional scores. We have 2 or 3 meetings a month to discuss patient outcomes and review every case at the hospital and our surgery center and our practice to make sure that we keep on getting better and better and better, and that we keep a certain standard. That involves length of stay and pain control scores and functional outcome and utilization of resources. And in all cases, more resources aren't better. We try to do what's called demand matching. So we look at the patient, what they need ahead of time, and ask them based on apps with this thing called Episode Solutions for Medicare patients. We look at rigorous pre-op planning, not just for the surgical part, but for the patient's needs, resulting in very, very low readmissions and complication rates. So we're really careful to look at these algorithms ahead of time. And if you look at our hospital, when patients compare us to Sutter, there's no difference in our outcomes versus the national rate in either facility, which is our local place. And the number of cases at Sutter is too small to measure for mortality or serious complications. And Dominican has enough volume with the Leapfrog group that puts it far above the other hospitals in the Bay Area. Even some of the ones over the hill don't want to put their rankings in because they're kind of not capable of having a good outcome. Whereas Dominican has always worked with the Leapfrog group to really put in solid data that's measurable by Medicare and other folks, and done very, very well with that. As you can see, the rating is very favorable, and that's a objective rating system, not paid for, and can't subscribe to it. So that's my talk basically, and I'd like to leave some time now for question and answer session. So if you'd like to do that, Leah, you can go ahead and do that.
Yeah, thank you, Dr. Abidi. That was great. A lot of good information. So we do have questions to start with. The first question is, I'm wondering for an 88-year-old healthy active man, what are the restrictions of, give me 1 second, I apologize, on activity after having hip replacement surgery?
So the activity level, so it depends on how far you're out from surgery. If you're far enough out, like we talked about, non-impact activities are really, really good. So walking is good, golf is okay. It depends on the amount of activity that you need to do, number one, plus also what your surgical approach was. To the anterior approach, patients are generally able to get back to anything they need to get back to, and we want them to get back to their activity levels. Things like running and jogging are not a good idea. If you have a posterior approach, doing constant flexion of your knee beyond 90 degrees isn't a good idea either.
Thank you, Dr. Abidi. The next question is participation in physical therapy post-op required?
Yeah, it is for knee replacements. For hip replacements, less so now. What we're trying to do is send patients for outpatient PT, and it depends on how much PT and how much work you did ahead of time. For the hip replacements, we know based on MRI studies that you lose up to 50% of your muscle mass. So working on your gait and station and avoiding falling, or at least getting checked out by a PT a couple times, is really, really important. And we have the capability now of doing video and remote PT and monitoring people at home, and not necessarily having to go into intense physical therapy. But for total knees, you do need to work on it much more intensely than hip replacement.
Perfect, thank you. How long does the hip replacement surgery last?
The hip replacement, do you mean the length of the surgery or the length of the duration of the component?
The duration of the surgery.
The duration of surgery. So surgery can range anywhere from the degree of difficulty from 35, 40 minutes to 2 hours to 3 hours, depending on the complexity of what has to be taken out. If it's a straightforward surgery, the average time is about 1 hour and 15 minutes to 1 hour and 30 minutes.
Okay, thank you. The next question I have here is, what's the difference between partial knee replacement and total knee replacement? I've also heard of resurfacing the knee. What does that mean?
Yep. So partial knee replacement is just replacing one component, the inside or the outside. And we talked about that with the Oxford partial knee replacement, where you're just replacing it when the rest of the joint's pretty healthy. The recovery is faster, there's less bone loss, but still you're putting parts inside. Resurfacing of the knee is, I'm not sure, that's kind of a vague term, frankly. I'm not sure what's referred to other than cartilage transplant potentially, because in all of these operations, we're resurfacing the knee. We're just choosing different materials to do that. And we're using right now titanium and chrome cobalt and plastic. So essentially we're taking smaller, thinner cuts generally with the knee that we showed today than some other prostheses which take pretty massive cuts sometimes.
Okay, thank you. The next question, is it safe to get a surgery done during COVID-19?
Right, so all of our facilities are currently checking how to do that in terms of checking and screening every patient ahead of time. So we're making sure that every patient is COVID negative when they come in the hospital. And currently at Dominican and at El Camino, there are very few patients in-house that are positive for that, and they're isolated in a different part of the hospital. So yeah, I mean, it is safe. So it's in terms of what we're screening for, we're really careful not to, we don't want to infect the staff or the faculty or the equipment of the facility. Every patient that's admitted goes through a COVID screening who's going to go to the operating room.
Thank you, Dr. Abidi. And the last question I have here is, could I have my hip replaced at an outpatient surgery center?
Yes, if you meet the health criteria, you can be replaced in an outpatient surgery center.
Perfect. Thank you so much, Dr. Abidi, for your presentation. I'm going to introduce our second panelist, Dr. Michael Nuzzo. Dr. Nuzzo, welcome.
Thank you, Leah.
I'm going to ask you to share your screen, your presentation, so we can start.
Okay, yeah, I'm here, Leah. Thank you. You want me to proceed, Leah?
Yes, please.
Okay. So my name is Michael Nuzzo. I'm an orthopedic surgeon in Capitola, California. So my specialty is in sports medicine, which means I mainly perform arthroscopic procedures of the shoulder, the hip, the knee, and the ankle. Arthroscopic surgeries are performed mostly minimally invasively through a camera in small incisions. This is a little bit of my educational background. I went to medical school at Rutgers University in New Jersey. I did my orthopedic training in Texas with Texas Tech University and with the Army as well at William Beaumont Army Medical Center. And I did a fellowship in sports medicine in Pasadena at Huntington Hospital. So just to clarify some definitions and terms to differentiate different problems with cartilage injuries. So an osteochondral defect refers to a focal or localized area of cartilage damage. And this is often caused by an injury. And the focus of today's discussion is the management of this kind of cartilage damage. This is differentiated or opposed to osteoarthritis, which Dr. Abidi just talks about, which refers to a biochemical process occurring in the joint that causes diffuse cartilage breakdown and loss throughout the joint, not localized, but complete cartilage loss throughout. And this is also known as degenerative arthritis. So what is cartilage? Some of the basics of cartilage. So cartilage is a resilient and smooth elastic tissue that covers and protects the ends of bones at the joints, and it creates a smooth, frictionless surface. There are cells embedded within the cartilage called chondrocytes that maintain its health. And those chondrocytes have a very limited ability to regenerate cartilage once damaged. So unlike other areas of the body, cartilage does not regenerate spontaneously. So the focus of today's discussion is on common cartilage restorative procedures that we utilize to treat focal osteochondral defects. And this is just an example here in the center of the knee, one of the femoral condyles of that type of injury. So
I hate to interrupt you. Do you mind sharing your PowerPoint presentation?
Sharing, oh, I'm sorry. I thought you were with me.
Perfect. Thank you so much. I appreciate that.
Oh, okay. Do you want me to back up a little bit, or?
No, that's good. That's all good.
Okay. So again, we were talking about how cartilage defects can lead to osteoarthritis or loss of the cartilage and need for eventually a joint replacement through biochemical processes. So focal cartilage lesions can lead to arthritis if left untreated. So some of the fundamentals of our surgical lesions are to induce cartilage through regeneration or to replace damaged areas to restore tissue that can function. Not all cartilage defects need surgery. Many injuries can be treated with conservative treatment, such as physical therapy or platelet-rich plasma. These do not regenerate, but they can help with pain. Plasma, a topic in and of itself and separate for discussion, but real quickly, they have the potential to reduce pain from mild arthritic changes in the joints or from chondral lesions. And PRP works by making use of the natural healing properties of platelets found in blood plasma. So these are the 3 established cartilage restoration options that are the mainstays of treatment currently used. So first is microfracture, which is stimulation of cartilage growth. The second is fresh osteochondral allograft transplantation, which is where we take cartilage and bone from a cadaver and transplant it into the area of injury in the patient. And the last is called matrix autologous chondrocyte implantation, or MACI for short. And that's a transplant of the cartilage cells taken from the patient that are sent to a lab and grown up and then transplanted back into the patient at a later date. Some of the experimental options out there are stem cells. They are purely experimental at this time. There's really no reliable data to show that stem cell injections regenerate cartilage, and currently stem cell injections are not FDA approved. So our treatment decisions are in large part based off size of the lesion or the size of the defect in the cartilage. And the arrow here is pointing to this. And so if it's a smaller defect, the first line of treatment for small areas of injury is microfracture. And we have seen good long-term results with this technique in smaller defects. The technique uses drills to place holes in their underlying bone, which you see here, where there is the damaged area. And this allows for cells from the bone marrow and also growth factors to come out of the bone marrow up to the an area where there is poor blood supply to stimulate cartilage growth on the surface. Here's an example. On the left side, you see intraoperative photographs of cartilage damage. And then this is on the tibial plateau. And then 2 years later, the same view, you see how the cartilage is regenerated. Here is on the bottom left, the medial femoral condyle, and you see the holes made with the drills. And 2 years later, the same view of the same knee with regenerated cartilage. Now these are very large lesions, and this procedure doesn't always work as well with larger lesions like this, but this is just an example of how a type of cartilage called fibrocartilage can regenerate with microfracture procedure. The advantages of microfracture is it performed arthroscopically, which makes it fairly simple and easy to do. It's inexpensive and has a long history of success. Its limitations is that it leads to the formation of a less resilient type of cartilage called fibrocartilage, which doesn't have the lasting properties of the cartilage we're born with, or hyaline cartilage. And it's not effective for larger cartilage defects. So for larger cartilage defects, the second option is a fresh cadaveric cartilage bone and graft, or osteochondral transplant. And these come from fresh grafts from cadavers that are transplanted into patients. The transplant occurs within weeks of harvest of the graft. And the advantages of this technique is it provides immediate durable cartilage or hyaline cartilage. And the limitations are it is more expensive and it does require an open procedure. It's not performed arthroscopically. So these grafts are ideal for transplant. They provide, again, durable cartilage that contains living chondrocytes and bone. This is just an example. So when we identify a patient that's a candidate for one of these transplants, we do an MRI, and then we use the MRI to match the size of the grafts to the patient's knee. And this is the form that we'll get that we can sign off on. You see down here at the bottom, the matched of size. It tells you the size and diameter. And it also gives you the age of the patient it's coming from, etc. So we confirm that the graft we're getting is the appropriate graft for transplant. Surgical technique, these are just some of the tools we use. This is just an example here on the top upper right. You see the cartilage defect. We drill out that cartilage defect and create a hole where the defect used to be. And that hole is then replaced with a plug from the cadaver cartilage and bone graft. And you see here the plug being drilled out and sized to the correct depth and then transplanted back into the defect. You know, and the trick here is to try to get the cartilage surface to be flush or the same depth, and that's the most important part of the surgery. And here on this picture, you can see that cartilage is pretty flush, a nice clean fitting plug. And many of these patients, we return them back to running and biking in 3 months, and many have returned back to pivoting sports by 6 months. This is an article by Dr. Bugbee, who's in Scripps in La Jolla. He looked at 149 knees in young athletes that had this procedure done. He found 91% of the patients were satisfied with the results of the surgery. This is a case example that I had done just about a year ago in a 14-year-old female athlete that had defect, osteochondritis dissecans, which is it's his osteochondral defect. You can see that here on the right side in the metafemoral condyle. Here in the x-rays, you can sort of see it too. On her and we found a very unstable cartilage defect that wasn't repairable. And so we did perform a microfracture procedure where you can see the holes here. This was a pretty large area, and she did not do well with this microfracture procedure. She continued to have pain. And so we proceeded with the fresh osteochondral allograft implantation. And you can see where we drilled our hole here. And then this is the cartilage plug from the cadaver that we placed into the knee. And she had, after 6 months, returned to sports with no pain in her knee. And the last and third option is matrix autologous chondrocyte implantation, again, MACI for short. And these are cultured cartilage cells that are taken from the patient and are grown on a collagen membrane. They essentially take a sample from the patient's cartilage in an area where it's not being used, or biopsy, and that's sent off to a lab, and cells are grown up and implanted onto the membrane. This has been FDA approved since 2016. It's largely a second-line treatment for younger high-demand patients with large defects. It is a two-stage procedure. So here you can, on the picture up in the right-hand corner, you see us taking a biopsy of the cartilage, and that specimen is then, sent off to a company that will grow the chondrocytes or cells in the cartilage up from a couple 100,000 to over 10 million cells. It's implanted onto a collagen membrane. And then about 6 weeks after the cartilage biopsy, we implant this membrane into the defect. The membrane is sized to the cartilage defect and then sealed in place with fibrin glue. Chondrocytes attach to the underlying bone and produce a new cartilage matrix. The best options for MACI are large, irregular shaped cartilage defects, like you see here on the right side. You can see how the membrane was shaped and implanted. Advantages of MACI, again, they're used for larger and irregular defects. The limitations, that it is a two-stage procedure, so there's 2 surgeries required, and it is fairly expensive. The same principles I just talked about, microfracture, fresh osteochondral allograft implantation, and MACI can be applied to all the joints, not just the knee, the shoulder, hip, and ankle. So what do I do? Arthroscopic microfracture is the first line of therapy that I use in smaller and well-defined cartilage defects. Fresh osteochondral allograft is a very good second-line treatment that I can use if microfracture fails, or I often do use it as the initial treatment in patients with larger chondral or cartilage defects. And then MACI is best reserved as a second-line therapy for very large, irregular shaped defects in younger patients. You can learn more about cartilage restorative procedures on my webpage, michaelnuzzomd.com, and thank you for listening. You there, Leah?
Thank you, Dr. Nuzzo, for a great presentation. We're now moving into Q&A session. If you have any questions, please send those over, and Dr. Nuzzo would be happy to address those. I do have a couple of questions to start with, and the first question is, how long does it take to recover from a knee cartilage operation?
Well, it's in stages. So typically you're preparing, meaning use a couple for that procedure. With the fresh allograft implantation, you're going to be non-weight bearing on that knee for 4 weeks, crutches, and thereafter that, 6 months.
Thank you, Dr. Nuzzo. The next question is, are there side effects to tissue grafts?
Well, in terms of maybe rejection, is that probably what the patient's asking? No, this is a neural type. It's not a type of transplant like an organ transplant where the body rejects it. But you do need to vascularize the graft, and so it does require healing. And there are instances where the graft just does not take. It doesn't vascularize and grow. And so in that case, the side effect is that the graft fails. But otherwise, it's just the typical surgical complications that can come with a surgery like this.
Thank you, Dr. Nuzzo. The next question is, what signs and symptoms of knee cartilage damage is in one's knee that would indicate joint replacement? And is it possible to resume the activity of non-aggressive snow skiing?
So as I mentioned, osteoarthritis. Clicking and mechanical symptoms, knee swelling, and identified with loss of the cartilage on X-ray. And that's typically when you would not be a candidate for the cartilage restorative procedures, but would go on to have something like Dr. Abidi talked about, a knee replacement with metal and plastic. Whether you can ski on a knee replacement, some surgeons do allow you to do that. Some recommend against it. I think, personally, I think skiing is a very healthy activity, and most knee replacements can handle that kind of stressor.
Okay, thank you. Moving on to the next question. What is the typical time length for knee surgery recovery?
Well, again, it's kind of a vague question, but it depends. Depends on what we do. So the arthroscopic microfracture is pretty quick. As I mentioned, a couple of weeks on crutches, and then you start to progress back to sports activities, usually within a couple months. And then the allograft transplantation, it takes about 6 months to return to any kind of pivoting type sport, about 3 months back to running, similar with Macy.
And thank you, Dr. Nuzzo. Next question is, do you have physical therapy available to speed my recovery?
Yes, we do. Physical therapy is something we work closely with. We have a physical therapy center here in Capitola. There's one in Los Gatos in San Jose that are closely affiliated with Ortho NorCal. And so, yeah, the physical therapist is somebody we work very close with and communicate with on a regular basis throughout the post-operative process.
Thank you, Dr. Nuzzo. Next question is brisk walking bad for people with low-grade cartilage damage? I'm a 73-year-old and otherwise healthy.
Oh, brisk walking is excellent activity. Staying as active as you can, your cardiovascular system healthy, and mental health as well. Being active is much more important than anything that may happen in your knee regarding any kind of cartilage degeneration or degenerative arthritis. We have very good solutions to arthritis of joints, including if they're focal. My discussion here today of cartilage restorative procedures, and if it becomes advanced and diffuse, knee replacements. We don't have great answers in medicine to heart attacks or strokes, and so it's much more to keep your cardiovascular system healthy, and then we can deal with any problems that may arise in your joints down the road.
Perfect. Thank you, Dr. Nuzzo. That's all for the questions today. If you have any additional questions, you can email us at marketing@orthonorcal.com or call 408-412-8100. I would like to thank everyone for joining us today. Have a great rest of your day. And thank you, Dr. Nuzzo, and thank you, Dr. Abidi.
Okay, thank you, Leah.
Thank you.